Good morning, everyone, and it's my great honor to present our study on lesion detection and localization using AI. Lesion is an abnormal change to tissue or organ occurring, caused by disease or injury. And lesion detection using imaging techniques is a very important clinical task. So take bone single photon emission tomography using MTP tracer as an example, where the lesion has increased uptake. Radiologists need to inspect transverse, corner, and the sagittal views together with maximum intensity projection images to identify lesions. They usually need to go through different slices, adjust contrast level, color map, and zoom factor to achieve the best performance. Lesion detection can be challenging and time-consuming, even for experienced radiologists. So the question is how to apply AI to lesion detection in medical imaging. The traditional approach is to train a neural network using labeled clinical data sets. And what we would like to do is we want to train a neural network using artificially inserted lesions. So if you train a neural network using labeled clinical data sets, there are a few problems. First, it requires a very large number of labeled clinical data sets, which are very difficult to have. Second, there's no guarantee that diagnostic information associated with each labeled clinical data set is accurate. Third, the patient-independent data shift, which is the difference between training and the testing data distribution caused by factors such as scanner type, image reconstruction protocol, can introduce bias. So our approach using artificially inserted lesions can have all those problems solved. First, we can generate almost unlimited number of training data sets using only a small number of human data sets, for example, 15 to 50. Second, we of course know the ground truth of artificially inserted lesions. Third, because we only require a small number of human data sets, we are able to generate sufficient training data for each type of scanner and each type of image reconstruction protocol to eliminate the problem of patient-independent data shift. So our approach is more suitable for nuclear medicine imaging. Also, it can be, in principle, applied to other imaging modalities. There are over 18 million nuclear medicine studies in the US every year. The demand is growing, and there's a shortage of radiologists, especially in many developing countries. And the radiologists' performance and their throughput are compromised by limited spatial resolution, high noise level, and the low lesion contrast in nuclear medicine images. So our approach using artificially inserted lesions can help radiologists to improve their performance and their throughput. So our approach can be applied to many clinical applications. For example, bone lesion detection using single photon emission tomography, which is what we have been working on so far. Bone lesion detection using scintigraph, and cardiac defect detection using perfusion SPECT. Tumor detection using positron emission tomography. So there are a lot of details about our approach and how to evaluate its performance. So here I'd like just to emphasize a few points. First, projection data measured on point source were combined with human projection data to generate lesion present images. Second, pairs of lesion present and lesion absent images centered at randomly selected lesion locations were used to train the neural network. Third, for testing, image patches centered at each voxel were fed into the trained neural network to generate a probability map for lesion detection. Finally, nuclear medicine physicians were asked to identify and localize lesions with confidence level for each test image volume. And the comparison performance was made between the trained neural network and the human observer studies. Receiver operating characteristic, that is the ROC curve, is commonly used in clinical radiology to express diagnostic accuracy. And you people have already seen many ROC curves in this conference, but I'd like to see a few more words. So ROC curve is fundamentally just a trade-off between the sensitivity and the specificity. The advantage of using ROC over sensitivity and specificity is that the ROC curve is independent of the threshold the observer chooses when interpreting the diagnostic exam. Similarly, localization ROC, we call it ARRC, represents how accurate lesions are localized. So higher the curve is, the higher the area under the curve, which is called AUC, and the higher the performance. So for this study, we have obtained SPEC projection data sets from 65 healthy subjects, and we used up to 45 of them for training, the other 20 for testing. So this slide shows the performance, the combined performance from 4 experienced nuclear medicine physicians. So the solid curve is the ROC curve, the dashed curve is the ARRC curve, and they are the concurrent fit to the data points using a statistical model. So if we train the neural network using 15 human data sets, the performance represented by the black curve appears a little bit better than the performance of the human observers. And if we increase the number of human data sets for training to 25, the performance represented by the green curves is further improved. And if we increase the number of human data sets for training to 45, the performance becomes even better. So if we compare the blue and the red curves, the trained neural network detects and localizes lesions with much better accuracy than the human observers. So the next step for us is apparently to apply our approach using labeled clinical data to evaluate its performance. And also, we have been working on bone single photon emission tomography so far. And in fact, in the future, we like to apply our method to other clinical applications, such as positron emission tomography. And I would like to thank many people who have contributed to the project, and of course, the partners, IDG grant. Thank you.